Yeah, thanks, Steve, and thank you all for sticking around for this important part. I just wonder if we'd, offered free drinks, if we'd get more people to show up. So today we're going to talk about the future in alcoholic liver disease or alcoholic associated hepatitis. I think many of us agree that this disease is somewhat difficult to diagnose and the treatments are suboptimal. So we're going to look at any ways that we can improve the diagnosis and look at better treatments that might be coming down the road. First one, in terms of the diagnosis aspect, is cytokeratin 18. Now, cytokeratins are structural proteins in epithelial cells. So that's hepatocytes, cells of the intestines, cells of the lungs. So they're not specific for the liver. But when you have liver damage and cell death, you get release of these cytokeratin 18 into the blood, and you can find an increased level. And there are two particular tests. One of them called the cytokeratin 18 M30, which is correlated with apoptosis, and then the M65 that's correlated with total cell death. And the cytokeratins are part of Mallory bodies. And in the graph on the right, you can see that in general, the level of, this is a cytokeratin, M65 increases with more severe liver disease related to alcohol. So HC is healthy controls, AUD are people hospitalized for alcohol treatment, but they don't have liver injury. AUDL is hospitalized with alcohol for alcohol use disorder, but with liver injury. And then you have moderate alcoholic hepatitis and severe alcoholic hepatitis. And you can see with each of those, the level of M65 goes up. Again, another study looking at M65 and M30 of cytokeratin 18, on the left-hand side for the diagnosis, and on the right-hand side for prognosis. If you again look on the left-hand side, you have alcohol use disorder, mild alcoholic hepatitis, and severe alcoholic hepatitis. And I'm going to have you look at the bottom one called M30. And that as you can see, there's an x-axis, and it's a little bit above the x-axis is a straight line, a solid line. That's the upper limit of normal of around 250. And you can see these people are very, very highly raised above the upper limit of normal. And on the right-hand side is the AU-ROC curves. In the cytokeratin 18 are in the top two, and our standard tests, Madrid discriminant function and the MELD score are on the bottom. And none of them is really all that good for predicting prognosis, but the CK18 is a little bit better than Madrid's or MELD score. And again, this is data on cytokeratin 18 from the STOPA trial. And on the left-hand side with all those pretty curves are different tests for diagnosing alcohol-associated hepatitis. And the two curves that are highest ones relate to cytokeratin M65 and M30. So again, those are better tests than other tests, not all other tests, but other serologic tests for the diagnosis of alcoholic hepatitis with AU-ROC of about 0.8. And on the right-hand side, it really shows response to prednisone treatment. Again, this is two graphs, survival graphs, with prednisone treatment versus without prednisone treatment. And it shows that the people that benefit were the people with a very high cytokeratin 18 M30 of greater than 5,000. Now, on the prior slide, I told you that greater than 250 was abnormal. So these people have a very, very, very high cytokeratin 18 M30 level. But yet, if you didn't have the very high level, you did not benefit from prednisone treatment. And using this test, about 87% of the people could be classified as not likely to respond to prednisone. So in their study, only about 13% of the people had the very, very high cytokeratin M30 and might benefit from prednisone treatment. So we don't have this, I don't have it clinically, but I think that we can sort of in our heads think that it's the very high, people with very high inflammation or liver cell death that might benefit from prednisone more than the other patients. What else do we have from the blood tests? Well, this is a proteomic study where they looked at 1,500 different proteins and then looked at their relationship with alcoholic hepatitis. And there are two sets of graphs. At the top, there are some proteins that increase as you develop alcoholic hepatitis, shown in those 4 slides, with the one group being healthy controls, another one being NASH or NAFLD, and the next 2 being alcoholic cirrhosis, either abstinent or drinking. And the final 2 little bars on the right are moderate alcoholic hepatitis or severe alcoholic hepatitis. And the set of graphs on the right-hand side, you can see that as you develop more alcoholic hepatitis, these levels of proteins decrease. And then looking at them more closely, they could choose 2 proteins, thrombin and hepatocyte growth factor alpha, that individually had a pretty good AUROC for the diagnosis of alcoholic hepatitis. And the 2 together had a very strong 95%, 97% accuracy for the diagnosis of alcoholic hepatitis. So some suggestion that proteins might be able to help us diagnose severe acute alcohol-associated hepatitis. It turns out that there are all sorts of little pieces of cells that are floating around in our blood that at least I wasn't aware of until, well, less than 10 years ago. And in this cartoon, you can see that different types of extracellular vesicles are thrown out by cells. And if you look at the bottom, you can see they range in size from very small to somewhat larger. And these ones, the one we're looking at there in the top pictures, are exosomes. And they carry what we call cargo, things in them that might be helpful from the cell that they're being released from. And so people have looked at these in alcoholic hepatitis. And here's a study that just looks at the number of different extracellular vesicles that are floating around in the blood. And in the top left, you have healthy controls, heavy drinkers, alcoholic cirrhosis, and alcoholic hepatitis. And alcoholic hepatitis is kind of the pink color. And you can see that just the number of vesicles floating around is much higher in alcoholic hepatitis. And in the middle ones, we have other liver diseases. We have healthy controls, NASH, and PBC. And again, alcoholic hepatitis has a much higher number floating around. And in the right-hand side, it's moderate alcoholic hepatitis versus severe alcoholic hepatitis. Again, higher number floating around in severe alcoholic hepatitis. And if you then look down at the ROC curves, you can see that the number of vesicles floating around can help you differentiate acute alcohol-associated hepatitis from other MELD-matched end-stage liver diseases or from decompensated alcoholic liver cirrhosis, which is a major ability if you can separate out those. Now I want to spend 1 second in looking at the y-axis, because I was a little surprised here. Just look at the number of vesicles that are floating around, and that's 10 to the 11th or 10 to the 12th vesicles per ml. That is a massive number of vesicles. And all this is happening in your body and my body and in patients with liver disease, something we generally don't think about, but that's a huge number of vesicles floating around in sick people and actually in healthy controls. Now this looks at the content of those vesicles. Specifically, it looks at microRNA. And microRNA, again, it's like proteins. There's a broad spectrum, and they have different numbers, not so much names. And in the 4 graphs on the left, there show you 4 different microRNA species. And again, healthy controls, heavy drinkers for HD, and AH for alcoholic hepatitis. And you can see for some of these microRNAs, the levels are decreased in alcoholic hepatitis, and in one of them, the level is increased in the blood in alcoholic hepatitis. And in the graphs on the right, you can see that the level can be correlated with survival in alcoholic hepatitis. So perhaps microRNAs may be useful for diagnosis and survival. Breath analysis, again, something we have to realize that, a lot of the compounds that are made by our gut and otherwise in our body may be exhaled in our breath. And these people analyzed exhaled breath from patients with alcoholic hepatitis and found that 2 particular compounds were increased and could be useful for the diagnosis of alcoholic hepatitis. One of them was trimethylamine, and one of them was pentane. And depending on the level that you set for the abnormality, you could either get a very sensitive diagnosis for alcohol-associated hepatitis, or you could get, if you set it at a higher level, you had a more specific diagnosis for alcohol-associated hepatitis. So I don't think this is used, but people could look at it as a very simple analysis. There are other tests that have been published that may deserve looking at in the future, such as cytokines and fibrosis ones like FGF19, and extracellular matrix proteins like laminin and collagen 4 that were, still could be used potentially in the future. So now I want to look for a minute on potential treatments. And this cartoon here shows different mechanisms of liver injury. One of them is oxidative damage directly from the alcohol and other pathways. And down at the bottom left is the gut, which we recognize is altered. And in the top right, inflammatory components, cytokines, cells, infiltration. And in the bottom right, you get apoptosis and cell death, but you also get regeneration. And all of these are different pathways that you can look at when you're looking at treatment. So the first one I want to cover is IL-22, which is, quote, a beneficial cytokine. And it's been used in this phase 1 trial where it was given, it's a fusion protein of an immunoglobulin plus IL-22. And they gave it to 9 subjects with moderate alcoholic hepatitis and 9 subjects with more severe alcoholic hepatitis. And they matched it with other patients that they had in their database. And you can see that the Lille score less than 0.45 is a score that's taken at day 7. And a less than 0.45 means that you have a very high survival. And so with the IL-22, 83% of the people had a low score, which is a very good number. Traditionally, it's usually around 55-60%. But in their historical groups, it was about 12% and about 55%. So a better response rate with this in a small study. And this is then going forward into an NIH-funded trial shown here, where patients will be randomized to IL-22 or prednisone, and then after day 7, they will then each group will be re-randomized to receive a camprosate or not a camprosate. And the outcomes will be looked at 6 months as some sort of decompensated liver disease or return to alcohol use. And so I think the people that live their life over on this side of the world know that treatments we've been looking at, steroids, IL-22, really they improve the liver component and hopefully relatively short-term survival. But long-term survival of these people really depends on whether they return to alcohol use or not. And if we can find something that reduces their return to alcohol use, I think that would be great. And so this is testing acamprosate as a treatment to reduce recidivism. This study, I think, is interesting. This was larsucosterol, which is a cholesterol derivative, and this is a phase 2b study where patients were randomized to standard of care, which could be prednisone or not, depending on the site. And then some of them received 30 milligrams day 1 and day 4 if they were still in the hospital, or 90 milligrams. This is an IV administration of this. And we'll look at it here a little bit. So if you look at the first row, about 100 people were randomized. And the second row, almost all of them, they had 90-day outcome, which was their outcome time. If you look at the next row, MELD of 25, that's moderately sick. And the next row, MADRS discriminant function of 60, that's pretty sick. So these were a sick group of people. Age of average about 45. And then the next group, just death. It was in the placebo group, 24.5% decreased to 15% to 17%. But some of the survival was related to getting a transplant. And so if you look at the very bottom, it was overall survival about 72% versus 80% versus 74%. And these are some of them, looking at them. And if you just look at 90-day mortality with the 30 milligram and the 90 milligram, you get a non-significant decrease, but clinically, if you could get a 40% decrease or a 35% decrease in mortality, you know what, that's pretty good. And in terms of adverse events, these are just listed here of any kind of bad liver-related outcome, such as ascites, SBP, sepsis. And when you take care of these people, it's often, they have multiple. They GI bleed, and then they get sepsis, and then they get multi-organ failure, and you kind of have to group it all together. And so these numbers are the numbers of people in each group that had one of those outcomes by day 90, by day 28 and by day 90. And so a lower number is better. And there's no statistics here, but you can just look at it and see that, generally speaking, the people that got the larsucosterol had somewhat fewer adverse events. This is one of my favorites. This was published 13 years ago, and I'm just waiting for it to be done again. Metadoxine is not a drug that's available in the United States, and this is a study from Mexico. It's an antioxidant. And just look at those survival curves. Prednisone alone, horrible. Prednisone with metadoxine, much better survival. And then they repeated the study where they added another study where they threw in pentoxifylline. And again, the two survival curves on the top got metadoxine, and the two survival curves on the bottom did not. So it looks pretty good, but I don't know if it'll ever be repeated, but I think it's worth doing. So intestinal dysbiosis is just really changes in the stuff in the gut. And I think even when I was training about 150 years ago, the idea of endotoxin being one of the things that might cause liver damage in alcoholic liver disease was studied. And it's just gotten more detailed since then. So we have bacteria and fungi and viruses, and all of them have been reported as abnormal in alcoholic associated hepatitis. Here is a meta-analysis of trials conducted in India with fecal microbiome transplantation. And there were prospective studies and retrospective studies, and the arrows there then point to the combined, and both 28-day survival and 90-day survival was better with the people that got fecal FMT. It has not been repeated in America that I'm aware of. These last two are, well, they're interesting. I mean, in the world that I live in, to find something brand new is kind of like, oh, that's nice. So this one is a very specific bacterium called Enterococcus faecalis. And in the graph on the left, so this bacteria sometimes carries a cytotoxin called cytolysin. And that cytotoxin is damaging to human cells. And so you can see that about 30% of the people who have alcoholic hepatitis carry Enterococcus faecalis that carries the cytotoxin. And on the right-hand side, you can see that the survival is related to whether or not you have the Enterococcus faecalis that carries the cytolysin. If you do, your survival is terrible. If you don't, then your survival is better. And so what these people did is that there's a phage, a tiny little, I don't know what they are, but they kill bacteria and they live in your intestines. And so the theory here is that you can take people, in this case this is a mouse study, but the ultimate would be humans who have this Enterococcus faecalis with cytolysin, and you could give those people a phage that would very specifically just kill the Enterococcus, and that would reduce the cytolysin production. And I don't really, it's kind of complicated to go through it, except to say that in the mouse study, this phage did reduce liver injury in mice that were colonized with Enterococcus faecalis that carries cytolysin. So again, the idea here is shown on the left in the kind of brown. It'd be a typical alcoholic associated hepatitis, where the bacteria could get through the gut wall and go to the liver, and directly or through the cytolysin cause damage to the hepatocytes. And on the right-hand side, the phages there kill the bacteria in the gut lumen, and you no longer get transport to the liver itself. The final one is endogenous retroviruses. Now what are these? Well, I think you probably know that the coding component of genomic DNA is, I don't know, 3% or 5%. It's a very small percentage. And if you look at, well, what's all the rest of it? Some of it looks like it could have been viruses that were there, from eons ago. And so the theory here is that these endogenous retroviruses, they exist in all of our DNA. They're turned off. They don't really make full viruses, but they can make parts of viruses. And in some diseases, if the turn-off mechanism is removed, you can get products of the endogenous retroviruses that might be causing damages in neurologic diseases and maybe in the liver. And so again, a little bit complicated, but this is a study where they looked at evidence for these viruses, these endogenous retroviruses, in the duodenum on biopsies of the mucosa in the top row. And in the bottom row, they look for evidence of activation and presence of the endogenous retroviral products in the liver, in humans, this is in humans. And some of them were increased in alcoholic hepatitis. The purple dots are all from patients with alcoholic hepatitis, and the gray dots are from normal people. So in alcoholic liver disease, there is a de-repression and a following expression of endogenous products from endogenous retroviruses that are normally in all of us. And here they took then they went to mice, and they gave them alcohol, and if you take the first one, serum ALT, there's a control. The first bar is just mice given food. The second bar is where they gave them antiretrovirals, and the combo is shown down there, emtricitabine, tenofovir, and nevirapine. And then if you fed these mice alcohol, you got an increase shown in the gray bar of the ALT. But when you gave them the antiretrovirals, the ALT went down. And if you look in the second bar, it's triglycerides. In the third bar, it's inflammatory markers. So antiretrovirals seem to knock down these endogenous retrovirus production. So this disease is high mortality, and people have looked at a lot of different treatments, and some of them are listed here. Some of them we need more information on, shown in the top and the list on the left. and some of them have been found really, I think, at this point to be ineffective. So you can just get the sense that there is a lot that has been going on in the field of alcohol-associated hepatitis. So in summary, we talked about tests for diagnosis and tests for possible treatment. We talked about cytokeratin 18, serum proteins, exhaled breath, and extracellular vesicles. And in terms of treatment, we talked about IL-22, larsucosterol, which is going forward in a phase 3 trial. We talked about fecal microbiota transfer, phage therapy, and a retroviral treatment against endogenous viruses, and metadoxine. Thank you for your attention.
Thank you, Dr. Flam, for this introduction and running the session. So over the next 25 minutes, good afternoon, everybody. My job will be to talk about how we can manage effectively alcohol use disorder in alcohol-associated liver disease patients. And I think the rationale was very well outlined and spelled out by Steve in the introduction. So after the disclosure, so I'll take a case which is my own case a few years ago during the COVID time. And this is a 34-year-old female who was hospitalized after a fall. And then she clearly has features of alcohol withdrawal, as you can see. And she has some comorbidities, metabolic syndrome. Her alcohol use is in the moderate range, 2 to 3 drinks daily since she was 16. And in the last 2 years, it increased to about 5 to 6 drinks daily, more severe. And then, more importantly, she had several healthcare encounters during her lifetime, including 4 years ago when she had a gastric bypass procedure. She lost 60 pounds, but she still carries a BMI of 28. These are her labs, which are, as you can see, are featuring chronic liver disease with alcohol-associated liver disease as an etiology, and imaging showed cirrhosis and clinically significant portal hypertension. So I think taking this case, there are certain, as you all may have noted in this particular presentation of the case, is certain points which I will go through over the next slides, highlight certain features this patient encounters. First one is that there were several encounters where there was an opportunity to identify a risky alcohol use and a harmful drinking, and maybe intervene to prevent cirrhosis, which was the ultimate outcome in this patient. And this was very well recognized in this publication almost a decade ago from Denmark, where 36,000 in this registry retrospectively shown a follow-up of 15 years. 5% developed cirrhosis, but majority of these had several healthcare encounters where there was an opportunity to diagnose AUD. And this was similar to what our patient in the presentation. So how do you identify or diagnose a risky alcohol use? And this is a tool which is most commonly used. There are several others, but for the sake of time, I'm putting the most common one here, which is, you all know, is alcohol use disorder identification test or audit. Is a tool where there is a test, 10 questions self-reported by the patient, each question on a scale of 0 to 4. But this is mostly used in research setting, and in clinical practice, it takes a lot of time. So a tool which is as good as the full tool is a brief version of it called Audit C, and where you talk about whether the patient is drinking and the amount of drinking or the frequency of drinking, and then the binge drinking, which is the third question, 5 or more drinks. And that is also self-reported, a total score of 12. And if you score more than 3 in a female and more than 4 in a male, you can identify alcohol use disorder. If you end up doing the whole test or audit tool, you can stratify diagnosis of alcohol use disorder at a score higher than 8. And the higher the score, more severe is the disease or disorder. At 15, you can make diagnosis of more moderate to severe alcohol use disorder. And sometimes when you put numbers into what the patient tells you, it actually shows how severe the problem can be rather than just listening to the patient. For example, I'll just give you an example here. I saw this patient 2 weeks ago in my clinic. The patient is reporting to me she uses a Friday or a Saturday of the week, twice a month, so every other week, she will use 5 drinks at a time, 5 beers at a time. And if you listen that 5 beers once a time every other week, that doesn't sound like a very severe kind of drinking. But when you put that number into this audit C question, she is claiming 2 points on all the 3 questions, making a total score of 6, which actually translates into a moderately severe alcohol use disorder. So that's why when you translate those numbers into this small audit C tool, which takes not more than 30 seconds, you can make a diagnosis there. Once you make a diagnosis of a risky alcohol use, then screen the patients whether they have underlying liver disease or not. Obviously, standard one is liver enzymes and imaging for any steatosis. Obviously, you have to exclude other liver diseases, Hep B, Hep C, and other liver diseases listed over here. And then if the patient has features of liver disease and you think that this is alcohol associated after you have excluded other things in a high risky alcohol use patient, the first test which comes to in a primary care setting very handy is a FIB-4, not only because it is fairly sensitive test, but also the algorithm which is used to calculate FIB-4 is very simple. You don't have to order very big numbers of tests. And at a cutoff of 1.3, you can segregate who is more likely to have a more severe liver disease or a fibrotic disease. And then the patient can have a second test, which is a fibroscan or VCTE, and a cutoff of 8, you can identify more. And then in a more specialized clinic, you can do more advanced testing, ELF test or MRE, and sometimes a liver biopsy. And this algorithm applies to patients, and you can stratify patients where you want to focus more on these patients who are more likely to be fibrotic and progressive. The second thing which we learned from this patient's presentation is she had a gastric bypass procedure 4 years ago, and then 2 years ago her alcohol use increased. Did gastric bypass procedure contribute to some extent her increased in alcohol use? And here are the data to show. On the left-hand side you see, and this is the veteran database or veteran study. On the left-hand side you see the MOVE program, which is a kind of a healthy lifestyle intervention in veterans. In the middle you see the sleeve gastrectomy patients, and on the right-hand side you see the gastric bypass procedure, the one which our patient underwent. And what I want you to see is the green bar and the empty bars, which is representing more severe alcohol use disorder compared to baseline when the procedure happened. At 5 years you would see the moderately severe alcohol use increased in patients who underwent gastric bypass procedure. There was no much change in MOVE program and in sleeve gastrectomy patients, clearly telling there is an association that after gastric bypass procedure, not only alcohol use, but other drugs also, and more observational studies are showing that addiction to alcohol and drugs, other drugs after the gastric bypass procedure. And a third and a very important point, which our patient highlights, and you would have heard this several times in the morning in the session with MetALD, an excellent session Louis ran with Zubair and others, is dynamicity of alcohol use. That alcohol use is never static and it changes over time. For example, our patient for the first 15 years was drinking in the range of MetALD, and 2 years since presentation as cirrhotic patient, she was drinking more heavily in the range of alcohol-associated liver disease kind of drinking. So something to remember, not only when you are treating these patients or addressing the alcohol use disorder in clinical practice in clinics, but also when you're enrolling in clinical studies, because the alcohol use is the major factor to decide what kind of steatotic liver disease the patient has. So the phenotype might change depending on the frequency of drinking and the severity of drinking. So this slide shows, let me show you, summarize the follow-up and what happened to this patient at 1 year from the presentation. The details of the case in more detail are published in Gastroenterology and Gastro Grand Rounds, but here is a summary slide to show what exactly happened. So month 1, when she was admitted for the first time with fall and alcohol withdrawal syndrome, and she underwent AUD treatment at that time in the community in an inpatient program, and she remained sober for 5 months, but as the disease strikes, she was struck with alcohol relapse 5 to 6 months after, presented with varicose bleed, underwent ligation. A month later had another varicose bleed, underwent ligation, this time had hydrothorax, ascites, underwent a TIPS procedure, and then a couple months later came back with severe alcohol-associated hepatitis, was lucky to respond to prednisolone, went home on a camprosate, and then remained sober for 2 months, and a third episode of relapse happened, came back with recurrent alcohol-associated hepatitis, this time was not lucky, developed multi-organ failure, infections, transferred to ICU, and died. Bad outcome. And we all see this kind of bad outcome in our patients, especially with severe alcohol-associated hepatitis, a condition we just heard from Tim about that is a high mortality disease. So what the main point, which is the focus of today, is highlighted by our patient where she had multiple relapses. If she had not relapsed, she could have had a better outcome, and this is shown in several studies. And whether it is an early stage liver disease or advanced stage liver disease or alcohol-associated hepatitis, is that if you don't control the alcohol use, you are driving the bad outcomes like hospitalizations, mortality, or maybe liver transplantation. And if you improve your alcohol use, then the recovery can happen. We have seen patients where patients from the transplant list have been delisted just because they have improved so much, and recompensation even can happen. So clearly showing that alcohol use in terms of what happens to these patients in long run can decide the long-term outcome of these patients. That is what we will talk about. And this is a meta-analysis we were fortunate enough to be involved in, where there are about 90,000 odd patients, where 1/3 of these patients were treated with some kind of alcohol use disorder. And the reference population was who did not undergo treatment, 2/3 of them. 14 studies, you would see that treated patients had a less likely odds of return to drinking and translated into better liver-related outcomes, whether it is mortality or readmissions and decompensation. So there is a benefit of improving long-term outcomes. However, in the real world, that's not what we see. It's extremely underutilized, AUD treatments. And this particular study, I think, comes from Texas, if I'm not wrong. I think it comes from Sarah Lieber's group in UT Southwest, and I think Mac is sitting here. It is from his center, where only 2% of alcohol-associated cirrhosis patients underwent AUD pharmacotherapy, as you see in this cohort of about 27,000 individuals. And in alcohol-associated hepatitis, about 10% of patients got treated. What is the reason why does this happen? And I think this is something we should know, and in terms of how we address alcohol use disorder in these patients. Are we stigmatizing the patient? One of the things when we talk or write or talk to the patient or do the semantics matter. So alcohol associated rather than alcoholic, whether it is hepatitis or cirrhosis or liver disease, so use alcohol associated rather than alcoholic. And secondly, exactly when we talk to the patient addressing their alcohol use, make sure that we are not letting the patient perceive that stigma, which I think is very common in these patients. So let me give you this video here, and this is a video, I don't think I'm breaching any kind of HIPAA here because it is openly available on YouTube. So I just put clips from the YouTube video. This is the guy who came in ER with a fractured ankle, and then the nurse practitioner who saw the patient in the ER is addressing her alcohol.
Yeah, that's a stressor.
Okay. So you've had some consequences related to your alcohol use.
I have.
So would it be okay if I give you some feedback about your drinking?
Sure, go right ahead.
Well,
I figure that's where you're going.
Well, you're right. And so from what you've talked to me about, it sounds that you drink about maybe 16 drinks a week, about 4 or 5 drinks a sitting. Is that correct?
Yeah, that's true. That's true.
Well, so this goes over the limits for males and females, and the limits for males are about 14 drinks a week. And when it gets to be more than that, it can lead to negative health consequences like high blood pressure, heart disease, diabetes. What do you think about that?
So you saw how she, the nurse practitioner, gave the feedback to the patient in terms of her drinking in a very, very non-judgmental and a very empathetic kind of approach of this providing harms and brief intervention, what can be the harms of continued drinking. And let me show you another when you try to give
on a
feedback.
scale of 1 to 10, 1 being not ready to quit all, you're going to walk out that door and have another drink, versus 10, how ready are you to make that change, with 1 being not ready to change at all, and 10 being, I'm ready to change as soon as I walk out the store.
5 or 6.
Okay, well, that's great. I mean, 5 or 6, that's 50 to 60% ready to change. So what makes you respond that way versus a 1 or 2?
Well, I sprained my ankle. My girl, she doesn't like it. Well, I'm doing this work. I'm not going to get paid for the day and tomorrow. So there's a couple right there.
Okay. So what do you think, what kind of steps could you do to reduce your alcohol use?
You just got to do like 14 a week and 4 a night. Well, we went down to 3.
You know, sometimes when I have patients making a change, whether it's dietary change or exercise or drinking, I have them write things down in a journal, like, for example, with alcohol. How many drinks they've had during the course of the day. How do you feel about doing something like that?
Well, I do it
Right.
every day. What I do?
Well, you could write it down, either the number of drinks that you've had, and I could give you a journal to write it in, or if you,
That's for me.
this is for you. And you could write in, and the days of the week are already set up in here, and you could either write the number down, or just a yes/no response, whether or not you drank or didn't drink for that day. Sometimes, you know, people have a difficult time remembering things.
Hell yeah. I'll start with the yes and no.
So you saw how she involved the patient into that shared decision-making, she did the motivational interviewing part of the whole thing and giving feedback and summary action plan. And let me show you 2 videos how you should not be doing it, but is a wrong approach. And you see right there you will see the end result of the interview right on front of the face of that nurse practitioner.
It can cause cancer, That being said, it can damage your kidney, lung, and heart livers, and I think it's important for things that change your behavior, maybe start going to AA meetings.
Let me go back a little bit here. 2 videos started at the same time. Sorry. Okay.
So in this scenario, cause cancer, cause things like pneumonia, it can damage your kidney, your liver, and those are things that, you know, you need to kind of function in your everyday life, and keep drinking will further impair those organs permanently. And it can lead to things like sexual dysfunction. We've already talked about having problems in relationships, specifically erectile dysfunction. And also it can lead to accidents, and you could, you know, injure someone else, injure yourself, and you wouldn't want that,
4 to 5 times a week.
right?
And
I don't know.
4 drinks a sitting. And
Plus,
had
I
some
don't have
backgrounds in the
erectile
past.
dysfunction. Where'd you get that?
Well, I'm not saying you have erectile dysfunction now, but if you continue to drink, that may be a definite consequence of
Yeah, I
you
think that's
continuing.
true, yeah.
You have your
Now,
continued
unless
use.
you said I
So do you
had
mind
it.
if we talk a little bit about your drinking,
And
what's
so,
good about it, what's fun for
with
you.
that
what
being
you
said,
Yeah,
I want you to
not
think
on
long and
that.
hard about this. And I think it's important that you need to change your behavior, maybe start going to ADAs, and just getting things back on track.
These questions, kind of a routine
Okay.
patient questionnaire. So just
What does that sound like to you?
patterns.
Yeah, I'll think about
So it has,
Okay.
I'm sorry, again, if I
Well,
can-
how about we touch base in a couple of weeks and I'll see where you're
Tell me
at.
again.
What about
your
my
drinking?
That's why I came
I
in the
have
first
to work. I
place.
work at a
Right,
machine shop.
that's right.
I
And
like
I'll
to
give you a
go take
prescription,
shower, have a
I'll
beer.
have it at the front desk before you
Okay.
leave.
So it kind
Okay,
of,
and well, I'll see you back here in a couple of weeks.
and are there
Yeah,
any other
might.
things that you'd like to do?
Okay.
other than you?
All right.
Yeah,
Well,
sometimes
we're
when I go out
You
with
could
my
see
fellas
that right in
on
that
weekends
patient
at
is
the
not going to
social
show
club.
up
We
at the follow-up
play darts and
because she
pool.
used a wrong approach
Well,
of addressing
you know,
the alcohol
I'm
use
like,
disorder. The other thing, I think,
about
more
4
than
beers
being
and
we
sometimes
being
we do
trained
shots
for
of
addressing
tequila.
alcohol use disorder,
So sometimes
is
when
that we
people are
lack
out with their
training
friends
also
and
on
they
using
find
AUD
themselves
medications.
drinking more, is that
And
ever
more importantly, that
happened
we
to you?
Yeah, when we
as
get
hepatologists
together,
and
it's a hoot.
gastroenterologists
It's a
are
hoot.
focused on the
So
liver
about
care,
how
and this
many
is a
times,
survey
like,
of 400
is
odd
4 drinks, 5
gastroenterologists,
drinks? Could you-
hepatologists done from
I'd
ASLD,
say
published in
somewhere
CGH.
somewhere
The
between
major
4 and
finding of this
sometimes,
survey
I don't know,
was
like
that
2 nights
perceived
ago, I think it could have been
by the
6, a little
gastroenterologists
fuzzy
and
on that.
hepatologists that they lack
Yeah.
training on AUD pharmacotherapy,
And
and
so
majority
you're here
almost
today because you
everybody
fell
said
on- you
they want
sprained
to be
your ankle.
trained.
Yeah.
And I think this is something which can
you tell
improve
me
the outcomes of
kind
these
what was
patients,
going on
that our
Oh, we're playing
gastroenterology
darts.
hepatology
We
fellowship
playing darts. I
incorporate
almost won
an
until I came in
AUD
second.
kind of a 7 or 8
Yeah.
week
How
program
many times do you
where it
win?
can be effective
I
and
won?
make them
Oh,
better
God, I
hepatologists
can't
in taking
count.
care
At
of
least
these
20.
patients. And this
I'm
is what
pretty
we did
good.
in a
That sounds
pilot
like a
study,
good
and this is
idea.
under
I don't wanna
publication
take it
right
on.
now, and where 20 academic
You're playing
hepatologists we
darts
took who were
and
trained by 7
how much,
addiction
I mean, you said
specialists
you
on
kind
an
of
echo-based
have a few
platform
when you're with your
with a
friends,
weekly
but how much do you think you
curriculum
were
involving
drinking before you
didactic
sprained your ankle?
presentations,
Yeah,
case
like,
presentations,
yeah,
and discussion.
that night was
There
pretty
a pre
wild.
and
It could have
post
been somewhere between 4
course
and 6
evaluation
beers.
showing an
Yeah.
improvement in practice,
Yeah.
So do you think the
competence and
alcohol may
knowledge.
have led
So
to
clearly in a
the
pilot study, it shows
ankle
maybe on a
sprain?
larger scale
Well, actually,
can be done the
yeah,
same.
come to think of it,
replicated,
good,
the
man.
study
I
to
mean,
show
I
the
live
benefits of
real close,
training
so I was walking
with a small
home. I didn't
course of
drive or
7 to 8
nothing.
Okay.
I was walking home.
So what are the
It's a usual
medications
path I
to treat
take. It's a
alcohol
short
use
distance,
disorder?
but I
The
went off
FDA-approved
a curb,
medications, Acamprosate is the
bam.
safest.
Wow.
It has no liver
hurt.
metabolism.
Okay. So how did
However,
you
you
get
should be
home?
cautious in people who have severe
well,
renal disease.
one of my friends,
Naltrexone, more and
other
more
friends was
observational
leaving,
data is
and
coming
he saw me.
To show its safety
Yeah,
in
so they put me in
the
the car and drove me
decompensated
home.
patient.
Okay.
Disulfiram should
So,
never be used.
besides spraining your
Actually, the
ankle, are there any
non-FDA
other
approved
kind of
medications,
maybe negative
baclofen and
things that
gabapentin,
happen
have more
when you
data
drink?
in liver disease
she doesn't
patients.
like it.
And
Sometimes
then
I
there
think
are
it's
dual
kinda
targets.
silly,
We
but
talked
yeah,
about GLP-1
she doesn't like it when
and
I
FGF21, where
tie
you
them
don't have the
on.
clinical
Yeah.
data.
Okay.
She has
GLP-1
problems
has
with that.
3 randomized
But
controlled
she's a
trials,
good
but
lady.
not in liver disease patients.
Scolds
So
me a
those
lot.
are something
Yeah.
potential
Yeah.
to be
What
seen
is
down
it?
the line. And
Yeah,
I think
so when
industry
she
is
scolds
thinking
you,
of doing studies
how do
in
you
MET-ALD
feel?
and ALD.
Oh, you know,
combination
like
using, these dual
sometimes
targets.
it's
So let
tail
me
between my
tell you
legs.
two dual targets, which are
she can really
LGG
crush it.
and
And
PUFA,
sometimes
and this
it's
is
just
the
we
LGG,
laugh
and this
about
comes
it.
from our center
But
in
she's still
Louisville,
kneeling me.
from Dr.
Yeah.
McLean's
Well, it sounds
group.
kind of like that's
And
a
this is
relationship
LGG, and I
study
think you heard
sometimes.
from
Oh yeah, it can. I
Tim
think. Well, she don't
about,
like it.
FMT
But
and
how can you better
modifying
say it?
the
Yeah,
microbiome.
That's the
And this is the
stressor.
same
Okay.
thing. I think when you
So you've had some
modify the
consequences related to
microbiome,
your
whatever
alcohol
way you
use.
do it, I think it gives you dual benefit on the
Would it
liver
be okay
disease
if I
as well as
give
in
you
the
some
gut
feedback
brain
about your
axis.
drinking?
With
Sure,
prediction.
go right
This
ahead.
is what we
I
showed
figured
in
that's where you're
moderate
going.
AH patients.
Well, you're right.
A randomized controlled trial that
And so
not
from
only
what
the
you've
liver
talked to
disease
me about,
improved,
it
but more
sounds like you
importantly,
drank
at
about
6
maybe
months,
16
the
drinks a
alcohol
week,
use
about
decreased
4 or
with this
5 drinks a
probiotic
sitting. Is
called
that
Yeah,
correct?
yeah, that's true.
GG.
That's true.
Well,
And this is another
so
thing
this
which is
goes over the limits
polyunsaturated
for
fatty
males and
acids,
females,
and there's a
and
lot of
the limits for
experimental
males
data,
are
but
about
now more
14
and more
drinks a week.
clinical data is evolving.
And when it
This is a
gets to
trial
more
which was
than
done at
that, it can lead
NIH,
to negative
where a
health
baseline
consequences
CSF
like high blood
examination was
pressure,
done,
heart disease,
and
diabetes.
12 weeks
What do you
CSF
think about that?
examination was repeated.
Wow.
And in the patients who
It
received
sounds like
PUFA
I
in
should
a
think
randomized
about
controlled
cutting
fashion,
back. That's what it sounds like.
There was a
Okay.
target engagement
So,
in the
on a
CSF,
scale of 1
and
to
this
10, 1
translated into a
being not
decrease
ready
in
to quit at all,
alcohol
you're going
use,
to walk out that
then
door and
decrease. improvement
have
in liver
another drink.
disease. So PUFA is
Versus
something which can
10,
be,
how
especially
ready
in
are
early
you
stage liver
to
disease,
make
can
that
be
change with one being
dual target.
not ready to change at all?
What about
and 10
hospitalized
being,
patients?
I'm ready to
I showed you
change
the
as soon as
data
I walk
on
out the store.
very low rate of AUD treatments in this population.
5 or 6.
But I think
Okay.
this
Well, that's
particular
great.
paper I put
mean,
here
5 or 6,
to show
that's 50
that
to
if you
60%
involve
ready to
the
change. So what makes you
hepatologists,
respond that way
because these
versus
patients are
a
being
1 or
treated
2?
by hospitalists and internists, the population is so large.
well,
So if you involve
I sprained my
hepatologists
ankle.
and the social
My
work or
girl,
psychiatrist
she doesn't like it.
right at that point before the patient goes home,
Well,
the
I'm doing
chances
this
that the
work.
patient will
I'm
follow
not
up,
gonna get
the chances
paid
that the
for
patient will
today
engage in
and
AUD
tomorrow.
treatment is much
So
higher.
there's a couple right
And this
there.
is what we
Okay.
need to do is
So
an
what do you think-
integration
what kind
program,
of steps could you
whether it
do
is in the
to
clinic or
reduce
hospitalized
your
patients.
alcohol
On the
use?
right
you
hand
said
side,
I
you
did
see a
like
more
14
apparent
a
liver
week
disease
and,
like alcohol-associated
4 a night,
hepatitis. On the
well,
left-hand
if it went
side, you
down to
see
3, that'd be
inapparent liver
less.
disease
I
where
think
the
I
patient
could-
is showing up in the
do
primary
that,
care,
just
or the
4 would
patient
be my top.
we just saw in the
Okay.
video in ER
sometimes
or in
when I have
addiction
patients,
centers. And then if they have liver
making a
disease, then
change, whether it's
integration will go.
dietary
Because they have
change
two
or
pathologists,
exercise or
they need two
drinking,
doctors.
I have them write things down in a journal.
And I think
like, for example, with alcohol.
Dr. Morgan showed you this,
how many drinks
the
they've
randomized
had
control
during the
trial,
course
which
of
is
the day.
currently
How do you feel
happening in
about doing
America
something
at
like
6
that?
different sites,
Wait, I do
including
it?
ours and
Right.
MAC, which is in Texas,
every day.
where
What
the liver
what I do?
Well, you could write it down,
with,
either the
IL-22,
number of drinks that you've had,
will be
and I could give
integrated with
you
AUD treatment using
a journal to write it in,
and then
or
the
if you-
long-term
That's for
outcomes.
me?
This is for you.
More than the
And you
liver
could
disease
write
outcomes,
in kind of
we
the
will also
days of the
study
week
the
already set
alcohol
up in
use
here.
outcomes,
And you
where
can
the
either write the
timeline
number
follow
down
back for
or
alcohol
just a
use,
yes/no
and we will
response, whether or
combine
not you
with
drank
Beth
or
level
didn't
as an
drink for that
objective
day.
marker.
Sometimes,
I
people have a
did
difficult
not
time
put a lot of
remembering
slides
Well,
on Beth
yeah.
because it was excellently
I'll start.
discussed
I'll start
in
with
the
the yes
afternoon.
and no and see if
And
I
then
can
we
do
have some
better.
metabolic outcomes
Okay.
and the
How's
patient.
that?
That sounds good. So I've
So I
written
want
down
to
for
summarize
you
my
kind of the
presentation,
things that we
and I
talked
think
about
I made
today,
my
and the
point,
fact
what
that
was
you're
given
gonna
to me, treating
do the
alcohol use
journaling,
disorder,
and then I'm
that we
gonna
should
give you a
screen
prescription
for
for
alcohol
your
use,
ankle
irrespective
and
of the patient
ibuprofen.
comes for,
Thank you.
whether
And
it
it
comes
was
to
great
the
talking
primary
to you.
care
Likewise.
or
Appreciate
ER
it.
or
Have a nice day.
specialist.
Yeah.
And then those who have risky alcohol use would screen for alcohol-associated liver disease. And we should address alcohol use disorder
Mr. Powell,
in the
do you mind
right
if we
way.
talk about your
just
drinking?
saw at
Yeah,
every stage
go
of
right
liver
ahead.
disease because it helps.
So it looks like you wouldn't
and
be
then
here
finally,
today if
we need
you weren't
strategies
drinking,
to
and you
improve
wouldn't
provider
have
training
any issues with your
on alcohol
ankle,
use disorder, especially
right?
gastroenterologists
Yeah,
and
maybe-
hepatologists,
maybe I
and then
guess,
more and more
yeah.
promotion for integrated
So there's some
collaborative
information
care
I want to
models
give to you
to take
about
care of these patients in
alcohol
a
in
more
your health.
holistic way.
And
In
I want
terms
to tell you
of,
that
their
when you're
true
drinking a lot
pathologies.
and
finally,
drinking heavy,
clinical
it can lead
trials,
to
actually, the one I
really
just showed you is
negative health
happening under the
consequences.
umbrella
It
of
can
NIH
cause cancer,
at 6 different
cause
sites.
things like
Should be
pneumonia.
integrated
It can
also
damage your
right from the
kidney,
time
your
the patient
liver,
is in the
and
hospital.
those are things
they are
that,
treating
you know,
liver disease and then they
you need to
translate into
kind
an
of
alcohol use
function in your
disorder,
everyday
not
life. And
waiting
if
for
you keep
them
drinking, it will further
to feel
impair
better
those
from the
organs
liver disease
permanently.
and then
And it
introduce
can
alcohol
lead
use
to
disorder
things like
treatment. Start sooner
sexual
than later to get
dysfunction.
better
We've already
outcomes in
talked
these
about
patients.
having problems
I
in your
would stop here
relationships,
and thank
specifically
you for your
erectile
patient listening.
dysfunction.
And I want to
And
acknowledge my
also,
collaborators,
it can
funding
lead to
and
accidents,
staff,
and
and
you could,
more importantly,
injure
patients
someone else,
for
injure
helping
yourself.
us
I mean, you wouldn't want that.
recruitment in the clinical
Right?
trials. Thank you very much.
I don't know.
Hi, good afternoon. Thanks
Plus, I
for
don't
staying
have
around
erectile
for this
dysfunction. Where'd you
session.
get that?
Well, I'm not
It's
saying you have
a,
erectile
pleasure
dysfunction
to be
now, but
here,
if you
and
continue
I
to
thank
drink,
the
that may be
organizers
a
for
definite consequence
developing a
of
session like this where we
you
talk about
continuing
alcohol
to have
addiction
your
in addition
continued
to
I
use.
thought you said I had it.
alcohol
No,
associated
no,
liver
no,
disease.
no. But it can be a common thing.
All right.
And so,
So I'll be
with
building on
that
a
being
lot of
said,
what my
I
colleague
want you to think
Dr.
long and
Singal
hard
said
about this, and I
about
think it's important that
the
you need
importance
to
of treating
change your behavior,
alcohol
maybe start
use
going to
disorder in the
meetings
context of alcohol-associated
and
liver disease,
just getting things
and
back
rather
on
than
track.
going into the specific treatments, talk more
Okay.
about the strategies that we can use and what's been
what does that
published in the
sound like to you?
literature on how to implement
yeah, I'll think
treating
about it.
alcohol use disorder in
Okay.
different contexts.
Well, how
so
about we touch
just
base
to
in a couple of
reiterate,
weeks and we'll see where you're
alcohol use disorder
at.
treatment has
What
been shown
about
now
my
in
ankle?
several
That's why I
studies to be
came here in the first
associated
place.
with better
Right,
outcomes
that's
in
right.
patients
And I'll
with
give you a prescription,
alcohol-associated
and
liver
have it
disease.
at the front
This is
desk
one of the
before you
first larger observational studies that
And
showed that
I'll see you
some
back
years
here in a couple
ago
weeks.
that in a large VA
you
cohort,
might.
receipt of alcohol use disorder treatment,
All right.
whether it was behavioral
good
or
talking to you, Mr.
pharmacotherapy, in this case they pooled those two together, was associated with less hepatic decompensation as well as all-cause mortality.
I wanted to engage
These
Mr.
findings have
Powell
been
initially
shown in other
and
cohorts as
find
well.
out
This is
where
a study
he
from
was
the
at,
MGH
in
group
regards to his
using their
alcohol
biobank.
use
They looked
and
at the association
doing
between
an
receiving
assessment of
alcohol use disorder,
what his drinking
treatment in the
patterns were
form
like,
of
and then also doing
pharmacotherapy,
some education
and liver-related
on my end
outcomes, and they
in regards
found
to the
that
consequences
there was a
of
lower
his drinking,
rate of
of drinking in
incident
general.
alcohol-associated liver
I wanted
disease
to
as
see where
well
he
as
was
hepatic
in regards to his
decompensation.
readiness to change.
Despite
And
this growing
if
body
see
of
that his use
evidence
may
and
have
what
led
we, I
to
think,
some
know to
negative
be
consequences,
intuitively
then
true,
that
there is a
lies
large treatment
the
gap, as
buy-in.
Dr. Singal also
And
pointed to, with
whether or not
regard
he was
to
ready to
a very
change
small
would then
number
lead
of
to further
patients with
negotiation,
advanced liver disease as well as alcohol use
as
disorder
to
receiving the care that they
what
may benefit
resources,
from. So looking at the
I would be
different
able to
studies
offer
that have
him,
reported on this,
and he'd be willing
that
to
first study
accept.
that I mentioned from
My
the
goal
VA showed
was
that only 14%
to hopefully have him
of individuals
see
with a diagnosis of alcohol use disorder
that he needed to
and
cut down on his drinking. And I
cirrhosis
didn't
requiring a
want to
hospitalization
infer
ended up
that
receiving
because that information needed to come
receiving
from
any
him.
AUD
In part, it
treatment,
would be
with less than 1%
throughout the
receiving
interview,
medications
negotiating
for
with
alcohol
him
use
and
disorder,
finding
consistent
his
with the
commitment
newer study
to
that
change
Dr.
and
Singal
wanting to
referred to.
change,
In a more
and
recent
where
study,
he was
also
at
based
in that
on data
process,
from
and
the VA,
providing him with some feedback with
9.7%
the
of patients
potential negative
with recent
consequences of
drinking
his
and
drinking pattern
alcohol-associated
if he was
cirrhosis and
able
alcohol use
to
disorder
come to his
were
own
noted to
decision,
receive
because then
FDA-approved
there's more of a
medications.
buy-in,
And in a
and
commercially
they're more
insured
committed to-
cohort, a large cohort,
He's more committed to change and
10%
continuing that
of
change.
patients attended any kind of mental health
What I would
visit at
do
all
to
who
engage
had
him
alcohol-associated
further and find
liver
out where his
disease, and
motivation
again,
is
less than
use the
1%
readiness
receiving
ruler
medications.
to
So
see
there's a
where
lot of
he's
work
at
to do,
in
and a
regards
lot
to
of
wanting to
different
make that
groups
change.
across the
It's all
country have
about
been looking
therapeutic
at how
alliance with the
to
patient,
implement
so
this
in that
and
sense, to get
make this
that,
more
it's asking the right kind of
feasible
questions,
and
open-ended questions,
patient-centered. And
and
so
engaging
integrated
him,
care, which
picking
I'll
up
go
on
into the different
little things,
definitions of that,
details
has
to
emerged
help
as
build
a
that rapport. For example, his
promising
relationship
way
with
of
his
delivering this
girlfriend,
care.
and,
And what it means is to basically
if there
meet
were
the
other
patients where they are,
variables
to use an
enhance that rapport
interprofessional,
throughout the
multidisciplinary
communication.
approach,
So
and
he's not
to
feeling
make sure
picked
that
on,
we're providing
so to speak,
evidence-based
about his
alcohol use
alcohol
disorder
use.
treatment in settings where patients are getting their liver care. So there have been a few really great summary and review publications from the group at University of Michigan, who I think they're now at Henry Ford Health, that I'll go over. And so just thinking about what integrated care means, there's a spectrum of integrated care and different levels of intensity, so it can look different in different places. So in this figure, the authors outlined that there can be informal collaborations where you may have a colleague that you know or a center that provides addiction treatment that shares patients with a hepatology or gastroenterology practice and their referrals back and forth. There could be a more collaborative arrangement where there can be co-located practitioners that are providing care. There could be simultaneous care where patients are being seen all in the same visit by all of the clinicians. And so all of these models are possibilities. We still need, I think, more research to determine what is the most effective and cost-effective and all of that, but I think it's helpful to know that this can be done in many different ways. In addition to the many different forms of integrated care, I wanted to also highlight that this can occur in various medical settings. I think the point of trying to improve or address the treatment gap for alcohol use disorder is meeting patients where they are and where they're interfacing with the medical system. So whether it's the emergency department or a hospitalization or an addiction treatment center or primary care or hepatology, our patients are kind of going to all of these places, and how do we make sure that we're discussing their alcohol consumption and addressing it where they're receiving their care. So one of the earlier models of integrated care again came from the University of Michigan group. So they had a very nice, robust, multidisciplinary team of a hepatologist, psychiatrist, a social worker, or a psychologist, as well as a nurse coordinator. And everybody would see all of the patients, kind of like how our transplant clinic runs, with multiple practitioners seeing patients and trying to be patient-centered. And they reported some early outcomes from this model, where they found that patients who who received care in this setting had a high rate of receiving treatment in the form of pharmacotherapy. So you can see that over 50% received a medication, which is much higher than like the less than 1% we saw in the other studies. And patients overall were using the emergency department less, had less admissions, had improvements in liver tests with receiving treatment for their alcohol use disorder. This was actually shown, this sort of integrated care model, many years back in a transplant clinic in Italy, where an addiction treatment provider was integrated into a transplant program, and they found that there was less return to alcohol use after liver transplant. So just highlighting that this concept has been in place for some time, and that newer studies have also shown similar outcomes. Many of these studies measure alcohol as self-report, which has been the gold standard in alcohol research anyway, using various validated methods. But nowadays with biomarkers, I think that the research landscape is shifting, and hopefully future studies will also use biomarkers to give us a little bit more robust information. Another setting in which there's been some early work done that has been very interesting is hospitalized patients with alcohol use disorders. So this is the group from MGH that published a couple of reports on their work on creating a kind of like a specialized consult service where patients who are admitted for alcohol withdrawal but not necessarily found to have advanced liver disease are seen by a hepatology clinician and the addiction medicine team, and then they have a FibroScan that's arranged, or a elastography test in the hospital, followed by probably a FibroScan in the outpatient setting to determine whether patients have advanced fibrosis that they may not be aware of. So they found that among over 100 hospitalized patients with alcohol use disorder, 30% had newly diagnosed alcohol-associated liver disease, and I think about a quarter had advanced fibrosis. And so kind of the opposite way, where we're looking in addiction treatment like settings to find patients who have liver disease, since it's silent until we have hepatic decompensation. So there are many different barriers to implementing integrated care, and I'll quickly kind of go through some and then talk about what in the future the efforts are to try to improve this. So there are patient, clinician, and systems level barriers, as there are for many initiatives in medicine. So on the clinician side, hepatology clinicians don't always feel equipped to provide this treatment. It's not part of our usual training. Many feel like they lack the knowledge and don't understand what the validated tools might be, but there's a great interest, at least in respondents of one large national survey, to have more of that training. From the patient side, Dr. Singal talked about some of the barriers already. Stigma is a huge barrier. Stigma and misconceptions about what alcohol use disorder treatment is, what the role of it is, how effective it is. There's also logistical barriers such as insurance, coverage, transportation, and there's also the barrier that many patients feel like perhaps they may not benefit from that treatment. And so integrated models are a great way to try to provide patients with that education when they're coming for other medical care, like their liver disease care, but they are resource intensive depending on how the clinic is set up, and so other efforts are probably needed. So what are some of the things that are barriers to being able to provide this care, and what could we potentially change? There's overall a shortage of addiction specialists throughout the country between kind of the opioid crisis and the rise in alcohol use disorder. There's a lot of work to be done and not enough addiction providers. And so I think that this is one area where training our gastroenterology and hepatology workforce, as well as primary care, will hopefully improve the way in which patients can access this care. Training and sort of how to implement that training into fellowship programs is another area where there needs to be more discussion and thought. I think some of this is starting, but very variable from program to program. And in my own experience, I did an addiction medicine fellowship before I did my gastroenterology hepatology transplant fellowships, and so that was my way of sort of getting that training, but certainly that is a long path, and so there can be ways to take that high yield information and incorporate it into our usual clinical trajectory in like transplant or gastroenterology fellowship. In addition, though, collaboration with the social worker is really important and could definitely help bridge patients to care from the inpatient setting. We did a study at our center that showed that there's this care cascade where individuals might see a social worker, but then not a smaller percentage get referred and then a smaller percentage establish care. And so I think the more steps there are to be able to engage in treatment, the fewer patients who actually do that. The timeliness of treatment is really important. This was a nice study that showed that patients who were admitted with acute alcohol-associated hepatitis who received their alcohol use disorder treatment earlier, so this group was looking at either residential programs or outpatient treatment programs or some mutual support group participation. Those who engaged in that within 30 days did much better as far as mortality as well as readmission and alcohol use than those who didn't have that early intervention. And then, of course, insurance and reimbursement are a challenge, and thinking of ways to improve parity for this type of care will help facilitate it. There's a lot of variability from center to center. This is a study that looked at liver transplant centers and what the types of clinicians and models of care are, and you can see that there isn't quite a lot of standardization, and so that may affect what patients have access to. And thinking also about harm reduction and talking to patients about cutting down on drinking and what that means and sort of how that can be a step toward abstinence, I think is something that has not really been studied greatly in the hepatology world. And so this is another area that I think there needs to be more research and kind of practice for clinicians to be able to have these discussions. Stigma we talked about, and then I also wanted to just touch on early intervention. Though the rate of underage drinking has been declining in the US, which is great to see, there is still a large portion of patients who have severe alcohol use disorder, many of whom started drinking earlier in life. And so collaborating with our pediatric and adolescent medicine colleagues to be able to help find ways of addressing this earlier in someone's life trajectory may have some benefits. And finally, we talked a lot about MET ALD and MASLD earlier in this during today, and so I won't go into a lot of detail, but certainly there is an obesity treatment gap in addition to an alcohol use disorder treatment gap, and there's some overlap between the strategies and some of the medications even that are being used, and so this is an area where we can potentially have synergy and more holistic interventions develop. So these are some of the medications that were already, I think, discussed earlier, but you can see that, you know, the GLP-1 receptor agonists are being studied for their role in substance use disorders broadly and alcohol use disorder. Naltrexone is a medication that Dr. Singal already went over that's used, that has really great data. For many of us, the first-line medication in alcohol use disorder that is also used for weight loss in a different combination. So there's definitely overlap, and as you can see here in the medications for alcohol use disorder. And I just wanted to highlight, in addition to what was said earlier, that the number needed to treat to prevent return to drinking in the medications that have been studied most extensively, the FDA-approved naltrexone and acamprosate is in the teens, and so this is on par, if not better, than a lot of the treatments that we prescribe commonly, such as statins and other types of treatments. So something to consider and also to convey to our patients that these are effective medications for a lot of people. So what are the next steps as far as implementing and studying these interventions? I wanted to highlight some research strategies that have been used to try to do similar work in other settings, primary care, emergency departments, HIV clinics, and implementation, science and implementation effectiveness trials are ways of gathering more data to be able to determine how to, in real world settings, make these interventions work and what components of these interventions are most effective. And so these are just some examples of studies that have used those methods. In our work, we've seen that there's a lot of variability among hepatology clinicians as to what they think would work best for them. You know, in integrating alcohol use disorder treatment, there are many ways to do it, and some hepatologists feel like if they're able to initiate medications and some of the treatments themselves, that may be more effective for their patients. And so in a study that we did to assess hepatology clinician preferences, over half of the hepatologists felt like a hepatology-driven model would be what they would prefer, and everybody felt like patients with alcohol-associated liver disease should receive integrated alcohol use disorder treatment. And this was a mixed method study, and so we just kind of looked at what the barriers and facilitators were and what some possible strategies are. In general, clinicians felt like there was low knowledge, like we already talked about, but that alcohol use disorder treatment was a high priority. Things like limited time and competing priorities in clinic visits were some barriers, as well as some anticipated patient resistance. And there are just some quotes here showing that hepatology clinicians overall feel like this is an important area that needs to be incorporated into our care. There's a trainee who mentioned that they felt like they were frustrated that they couldn't kind of continue the conversation they were already having about alcohol during the visit, which we all talk about alcohol with our patients commonly, and just kind of start the treatment process. And so kind of again showing that hepatology clinician-driven models may be feasible and of interest to clinicians. When it comes to what might help, clinicians felt like if there were algorithms and clinical decision support tools, those may be things that can help make it easier to be able to start prescribing medications for patients. But there were also some who felt that a dedicated addiction clinician in the clinic would be a more effective model. So I wanted to just quickly highlight kind of what our model looks like, which is a little different from the Michigan model that has a lot of different clinicians working together. So the clinic that I'm a part of, we have a small behavioral health team, but primarily it's sort of integrating a medication management type intervention into usual hepatology clinic visits. And so we have been in place since 2021, and overall there's a relatively high rate of patients taking medications for alcohol use disorder as well as behavioral treatments. We haven't yet looked at our data as far as outcomes for drinking, but that's in process. I wanted to highlight some resources that are available with the growing interest. There's a lot of really wonderful, freely available resources to learn more about treating alcohol use disorder and other addictions in liver clinics. So the NIH has a great resource that was developed, a peer-reviewed resource developed a few years ago. There are podcasts as well as short reports on Liver Fellow Network. The AASLD has a whole series of modules on liver learning, on treating addiction, one of which, or several of which, address alcohol use disorder treatment. And then there's a new initiative from the American Society of Addiction Medicine, collaborating with many organizations, including the AASLD, to provide a lot of free training on alcohol use disorder care across many different settings, including liver disease settings called PCSS MAUD, and the link is also listed here. So in summary, integrating alcohol use disorder treatment into liver disease care will require a multifaceted approach to help improve our workforce capacity, and also to be able to study what components of the interventions work in which settings and how well. Implementation research will be needed to be able to do that, and strategies to improve kind of the financial ability to be able to provide that care, as well as to dismantle stigma that affects both patient and clinicians' ability to provide this care will be important. And finally, collaborative approaches with all types of steatotic liver disease, including MASLD, may be a way to reach more patients and to kind of address all of a patient's risk factors at the same time synergistically. Thanks.
Okay. We do have some time for some questions. Hopefully you guys have some questions about this very common problem and some of the vexing issues that you face when you take care of patients with alcohol-associated liver disease and alcohol-associated hepatitis. We have our three speakers here, and I'd also like to introduce Dr. Robert Brown, who's Chief of GI and hepatology at the Weill Cornell Medical School in New York, and was editor of Liver Transplantation through, I think, a few months ago, and has many other accolades, which would take us the rest of the time that we have to go through, so I won't go through any more of them. But please ask anything you want, and I'll ask some questions too that I think are of interest. Brian?
Okay, great. Congratulations to the speakers. Really thorough and excellent session. I really had two questions. The first was about messaging about alcohol. I think the public has really received a lot of mixed messaging about the safety and what can they drink. So, I know that we talked about AUD and ALD here, but, and it's very clear that patients with, advanced fibrosis or AUD, the messaging should be really no alcohol at all. But, the most common patient that we see now is, MASLD with minimal fibrosis. They enjoy drinking socially. So how do you approach your discussion with alcohol with them? Is there a safe level of drinking? So that's my first question. And then the second question is about integrated care. I think all of us agree as hepatologists it's the right thing to do. But the reality is that it's highly resource intensive, and hospital administrators, who are important stakeholders, don't always agree that it's the right thing to do. So is there any cost-effective analysis that you've done at your centers? And what is your approach? And maybe, Bob, you can give us some advice on how do you convince the hospital to invest in this?
So did you direct it to somebody, or do you want me to?
Yeah, the second question would be to, Lamia and Bob, I guess.
And the first question?
First question to anybody.
Tim?
So I can start. Coming to your first question, I understood the latter part of your first question regarding addressing alcohol use in MASLD patients. I think once the patient has liver disease, and I think we all have seen the data evolving, more observational, that even within the MASLD kind of drinking, even that kind of drinking, if you subdivide into very low or within that 0 to 20 or 0 to 30 grams, depending on the gender, is associated with worse outcomes. So when I see my patients, I'm very upfront, and I think most of us are. If they have liver disease and they're doing any kind of drinking, they should abstain from alcohol completely. Because more and more data is coming that any drinking can be hazardous, unless in the randomized controlled trial or any kind of MET-ALD or MASLD or even alcohol-associated liver disease. The one I think Tim and I showed is happening in severe AH patients. Unless we show in a randomized controlled fashion that the outcomes are independent at a certain cutoff of alcohol, where it doesn't matter in terms of the outcomes, but we don't have that kind of data right now. So I tell my patients to stay away from any kind of drinking. In terms of your second question, which is about the systematic barriers in implementing integrated care models in overall, that's the dream of any hepatologist, you and I and anybody in this room, that we have that kind of model to take care comprehensively of these patients. But you are absolutely right. There are and the whole team has to be on board to implement these kind of models. My personal approach, if I can use the word, to address, because we need to take care of these patients, is a modified approach, and I am struggling the same way at Louisville to develop this kind of integrated care model. And my personal modified approach is, okay, I'm going to learn how to address alcohol use in these patients, and then have the comfort level on initiating therapy for alcohol use disorder in these patients. Those are the two things which I do. But then when things get a little bit outside my comfort zone, for example, if I have to prescribe a medication for depression or anxiety or insomnia, which are so common in these patients, I have a psychiatrist handy on my phone call, and I give a call, and I know when I call him, if he's in town, he'll pick up the phone. And it's kind of a modified integration, if I can use the word, and I get the answer there. And then in more severe alcohol use disorder, I have community resources and others. And obviously, if the patient is motivated, if the motivation level is 5 or 6, the one we saw in the interview, I gave them community resources in terms of getting addiction training. But I leave to Lamia, who is integrated person in itself, to have both the addiction medicine and hepatology training. Maybe she can address it better.
Sure. Yeah, that was great. I'll try to be mindful of the time. I think the first question, I'll just say that, especially with the Surgeon General reports on cancers, I think it's become a little bit easier to address some of the misconceptions around alcohol. And so I think that I sort of tell most of my patients there's no safe level of alcohol, but that the risk increases with the quantity and the frequency, and kind of counsel patients that way. I think that, you know, the lower risk drinking guidelines that the NIAAA had, I think have been kind of misunderstood a little bit for a long time. The caveat to those thresholds is that if somebody has a medical condition, any medical condition, hypertension, you know, diabetes, whatever it is that could be impacted by alcohol, those thresholds don't really apply to those patients anymore. And so I think that a lot of us maybe forget that and sort of say these are like the lower risk drinking thresholds, but there's a lot of people on whom those thresholds aren't actually this quote safe or even potentially low risk thresholds. So I think just reminding ourselves and also patients about that is helpful. So that's sort of the first question. For the second question, I think that, I think that medical management models have been studied pretty extensively in the addiction sort of treatment research world. There are large trials of, like, you know, somebody like myself prescribing a medication for alcohol use disorder compared with kind of a mental health clinician, or combining those treatments. And overall, there was either not much difference, or maybe the medical management model in some cases was even better. And so I think that there is a lot that we can do as far as being able to start treatment and pairing it with what we're doing already in our hepatology clinics. But I do certainly appreciate the challenges of not being able to maybe have patients come back very quickly to reassess them, you know, withdrawal management, all of that. And so I think that having those collaborations, knowing where the local detox centers are, and like having like a little sheet of like what are those places, who are the other kind of addiction treatment people in your institution or in the community, and having those resources for the patients. It's not ideal, but I think that it's a very doable model for us. And I think when approaching hospital leadership, I think it's very variable from center to center. I think pairing with a transplant program can sometimes help, because if we're able to kind of also support the efforts of the transplant program, then that can be financially maybe a reason to invest in patients, you know, in ALD in general. I think that also if there are initiatives for population health and prevention, those are the types of sort of initiatives you can kind of try to align yourself with.
Great, thanks.
My right side, Mike.
Yeah, so I think one thing that I've been seeing, so at UCLA we actually have an integrated care model with hepatology and addiction medicine. It's actually not even prescriber willingness, like for these prescriptions, but actually patients' willingness to take the medications and continue taking some of these medications for AUD. So do you all have, you know, any guidance, or, you know, how do you counsel your patients on, you know, being agreeable to taking some of these medications like naltrexone and acamprosate, and then continuing to take them even though they may not feel a benefit from it day after day, but just, you know, needing them to be on it? How do you all counsel your patients on that?
So the question is, how do you make sure that the patient is compliant and adhering to taking the medication? Is that correct, if I understood it correctly?
Yeah, that they're willing to even take the medication, to start taking a medication, but then also to continue it over time. To continue, like to start the medication and then to also continue taking it.
Adherence.
So it's very, I mean, the first thing, if that motivational interviewing you do with the patient, if I'm doing that, or we are doing that with the patient, if I get the body language or actually a clear answer that I don't care, the moment I walk out this door, my motivation level is zero, that patient is not getting an acamprosate or naltrexone prescription from me, because I know the patient is not motivated at all. But if the patient's motivation level is good, then I'm comfortable prescribing the patient with any kind of AUD medication. Acamprosate is my top medication to prescribe, but I've changed depending on also precision, if I can use the word, depending on associated comorbidities. For example, if the patient is having a neuropathy significant, then I'm more inclined to prescribe gabapentin to this patient. If the patient has a very early liver disease, early stage liver disease, or maybe compensated cirrhosis, then I'm more inclined to prescribe naltrexone, the advantage being then I'm reducing the pill load from 6 to 1 or 2 maybe per day. So I can change my, depending on what the patient has more spasms and things like that, the baclofen might go as a choice. So depending on the comorbidities of the patient. And then obviously it is very difficult to monitor. I mean, in clinical practice, I wish I could see these patients every 2 weeks like they're supposed to be seen for addiction part. That's where I'm struggling, that we have to see these patients 3 months or 6 months depending on their liver disease and not depending on their addiction, that we can see these patients every 1 or 2 weeks. So that's where I think when we come back, a patient comes back in 3 months or so, the patient may not be taking and may have taken it for 2 weeks, and then, so I don't know the answer to that, how to improve the compliance and adherence to the medication in that particular patient. But what I think Lamia brought up a good point on prescribing or managing their alcohol withdrawal. Some patients will tell you, because if I go cold turkey, I am concerned that I might get withdrawal because he had that before. And I think I'm getting more and more comfortable, and I think everybody in this room is, to prescribe a short 5-day course of short-acting like lorazepam or something to take with the patient, and I tell the patient that don't worry, start taking this today, and then go cold turkey, and if there are withdrawal symptoms, you'll be fine with that. But if it is not, then you come to the ER. So I think my comfort level is getting better in prescribing that short course, 5-day course of lorazepam to the patient when I'm sending them if they're at a high risk of alcohol.
Bob, any tips on adherence in your practice? And one other thing, it seems to me that we in the hepatology world don't do a very good job of training our fellows, and this was alluded to by Dr. Haque, how to deal with this issue. We talk about alcohol use disorder being important over the long run, but we don't actually teach, maybe you do it in Cornell, we don't actually teach fellows about how to treat alcohol use disorder. And I'm not sure you need to be an addiction medicine specialist to prescribe naltrexone. But do you have any initiatives at Cornell?
I think the mistake is treating it differently than other diseases. When you prescribe carvedilol to prevent bleeding from esophageal varices, it's not going to make the person feel any better. Matter of fact, it might make them feel worse. But what you do is you tell them this is important. It will reduce your risk of bleeding. It won't eliminate your risk of bleeding. I think many people fill patients with unreasonable expectations about the efficacy of medications to reduce alcohol use. And then if it doesn't work, meaning they take it and they still have a drink, it's like obviously that medicine didn't work. So it's all about expectations, setting reasonable expectations, and importance. If you say it's important that it will have meaningful impact at reducing, not eliminating, reducing the amount that they drink, reducing their cravings, and that if they continue to take it in conjunction with counseling, et cetera, they may achieve their goals, they are more likely to be compliant. If you say, this will stop you from drinking, just take this, and of course it won't work, and then they'll stop. But we're not surprised when patients don't lose weight, when they don't control their diabetes better, when their blood pressure at each visit is not well controlled for hypertension, and yet we continue to work at it. And I think if we take that same approach with alcohol, we'll do better. But when you put it in a separate bucket from other diseases, then you have, though you say you want to destigmatize, you've actually stigmatized, because you've made it different from other diseases, when in reality it isn't. Any more than when patients say they're hardly eating, you still will send a hemoglobin A1C and you'll say, not doing as well as you should. Let's try to do better. And I think that has to be the approach in all of these things. If you take a black and white approach, no drinking, then once they start drinking, there is no limits. I think your point, less is better. 0 is the best. And what I often say is, if I had liver disease like you did, I wouldn't drink at all. And I know that because it's true. But if you are going to drink, you better keep it to 1, and you better keep it to special occasions. And every day isn't a special occasion, at least not for me. And then when you make it seem less judgmental in the way you present it and more realistic, you'll get better success in all things, alcohol included.
Are you training your fellows, though, in this regard? I mean, because I don't think a lot of fellowship programs really do.
I don't know, Danny, do I train my fellows? I think they watch me, and hopefully the knowledge just goes all over them. No, I think we do train our fellows. I think we have a really good alcohol program that Steph Rutledge started when she was here, and now Rebecca Roediger is going to take over. We do have an integrated program, but the truth is the integrated program only works for a minority of patients. 4 years, 200 patients. There are more than 200 people with alcohol-related liver disease in New Haven. I've been there. And so we need to do it in our general practice and then save those things for the harder cases.
So I think commenting on what you just said.
Let's do another question.
Yeah, otherwise we're going to just get
We got to move
all tied up.
Great. First of all, congratulations. This is an outstanding session. A comment. Look, and Dr. Morgan, thank you very much for discussing the AFFIRM trial, the formerly known DUR 928 and currently known larsucosterol. Actually, looking at the data based on where the sites were located, US versus the world, the US data actually revealed a 60% decline in death rate. So based on this, actually, there is a phase 3 trial that started. The name is the ReAffirm trial. Hopefully, we will have some encouraging results shortly in the future. And my discussion, and actually my question will be pertinent to the GLP-1s dual agonist along with the glucagon receptors. As you know, there are 2 trials currently going on with pemvidutide. One is for heavy drinking, the other one is for alcohol-associated liver disease. So what's your take on the GLP-1s and glucagon receptors for patients with alcohol-associated liver disease?
Yeah, so I think the question is, what's my take on GLP-1s for alcohol-associated liver disease? So one of it is do I have an opinion on whether they help the liver disease? And maybe the second part is, do I have an opinion on whether they help the alcohol use component? Would that be a fair way to break it down or not?
Yes, actually, the dual agonist, GLP-1s and glucagon receptors, because glucagon receptors exist in the liver, GLP-1s.
Glucagon receptor. I don't have enough knowledge on that in alcoholic liver disease to tell you. Sorry.
Because the philosophy is the one is blocking the craving, the other one is defattening the liver, decreasing the inflammatory stress.
I think I agree with Tim about that there's no data on...
the pemvidutide trial, actually, that has already started, the name is the response. The recall is for behavioral, and this one is targeting, actually, patients with alcohol-associated liver disease.
I don't think there's enough known as to whether these drugs act directly on the liver or they just act on the things that affect the liver. And I think it's interesting, but the presence of a receptor in the liver doesn't mean it's going to work. I think we have to wait and see the data.
Well,
but I think the more potent ones are going to reduce alcohol more. And we haven't measured that impact even in the trials for Mazdut. And so it's still I think, too early to tell.
Actually, alcohol goes higher because GLP-1 is blocking the CYP2E1 and decreases actually the amount of the enzyme and acetaldehyde. So alcohol is circulating for a higher amount. So long story short, let's wait for the results of the trial then. Thank you.
But Nick, just to answer your question, even if you see the GLP-1 3 randomized controlled trials in AUD, no liver disease, in AUD, the results have been very heterogeneous. So it does cross blood-brain barrier, we know that. It does act on the addiction center. It might be helpful, but I don't think the jury is out that it does help alcohol use disorder. Forget about liver disease, we don't have data on that. And there are no trials, so the trials are being conducted.
That's why I ask in particular for the dual agonists. Okay. Thank you.
Fred.
Thanks for educating us. That was a great session. I think I counted 3 slides that had the word liver transplant on them. And so I'm curious in what people think the role of liver transplantation is in the treatment of the continuum from acute alcohol all the way through cirrhosis. Where does that fit in?
So can you repeat your question?
Yeah,
the role of transplant.
The role of liver transplant
for treatment of alcohol-associated liver disease.
Thanks, Steve.
I mean,
Bob, you can take this one.
It's going to be a minority. I mean, if you think about there were probably greater than 50,000 deaths from acute alcohol-related hepatitis and ACLF from alcohol. Even if it's all we did in liver transplantation, it wouldn't touch it. And so I think we could debate what the impact is of liver transplant as a life-transformative event on the risk of going back to drinking. Unfortunately, seriously biased by the selection of the candidates that we take. But I think we all are missing the boat when we think that transplant's going to be the fix for this problem. It just isn't. And even among transplant centers where they say, oh, we transplant them, I've heard this yesterday, we transplant almost everybody we see with this. And the answer is, first, they don't. And second, they don't see the majority of it. It never gets to them. In community hospitals, the first treatment recommended is generally hospice care. And so I think that it's great to focus on how to maximize the use of transplantation in alcohol-related liver disease, how to make it fair, how to make it equitable, and then, of course, to minimize relapse to heavy alcohol use. But to think of it as a treatment for advanced liver disease, except in the minority, I think is just not really going to touch the mortality from this. Never mind the mortality, that half of the mortality from alcohol is non-liver, it's accidents and death. And really what we need to do is do a better job of treating alcohol use disorder.
Mild.
Okay. It's interesting in the discussions we've had here tonight, and this exercise has been terrific. But nowhere in all this did I hear any mention of AA. Now, our services in handling patients or in dealing with patients who are even expressing an interest in getting off alcohol is limited because of the facilities and the onslaught of patient numbers. Where do you see AA fitting into the effort to get patients off of alcohol? We do know successes, but is there any interconnect between any of your programs and the multiple
Yeah, I can address that. Thank you for bringing that up. I think that mutual aid groups like AA and others, AA being the most well-established and widely available, are really important and have great data to back up their use. I think my approach when I see patients individually is to give them the whole menu of options. So these are the medications, these are kind of the different behavioral treatment options, and these are the mutual aid resources, including AA, which can be very effective. I think patients have different reactions to AA. There's some misconceptions maybe, and there are also patients who've experienced AA who maybe feel like the way in which the sessions occur may not fit with their approach. And so I then kind of talk about some of the other alternatives like Smart Recovery and the many other alternatives that are available. I'm not aware of, my center isn't formally affiliated with AA, but I think that we always kind of provide the information as to how to find meetings. I talk about the fact that every meeting is different, that there are different kinds of meetings, and so patients often kind of go to, if they're interested, go to different meetings and find the one that feels most like the best fit.
The only true barrier between the patient and AA is the willingness of the patient to go, to demonstrate an interest in it because they genuinely want to get off it. And they're much more familiar with AA than anything we've set up in any institution. And so I think the more they're involved in a physical manner, that is interaction with presence of both in the same place, making plans to actually refer to AA, specifically, not just say go find one, but to direct them.
No, I think what Lamia just mentioned about the AA and the behavioral treatment, especially in hospitalized patients, one of the things which I kind of, and I think Lamia might know more than I do, that some centers are now, addiction centers, for several reasons, are even entertaining patients to have kind of a digital format, and some patients have the stigma of going to an addiction center, and that may deter them from not going and taking these therapies in the right kind, including AA, what you just said, and there is a mixed response from patients. And if they are given the option, or they can find a center where a digital option or a virtual platform option is available, then they may be more acceptable or to take that treatment.
Yeah, and I think there is a website that where an AA meeting starts every 15 minutes, around the clock, and you can drop in, and it's free. So that's another option along the lines of what you were saying if they don't want to physically go someplace.
Yeah.
Paul.
Oh, and LifeRing also is another more secular version of this you can get online. We often have our patients in the hospital on an iPad, starting there, just to get engaged. I'm sure we're not the only center that does that. This was a great discussion. Just had two-part question. Number one, and there's probably literature here I'm not very well aware of, but what are the experiences? Have people tried to use natural language processing or large language models to cull the electronic record, just like we cull for sepsis, to cull for alcohol use disorder, in order to identify these individuals earlier? Ashwani, you had just said how the audit actually is quite useful. It's part of what I do when we see the patients. But if you give a BPA to a primary care doctor, they'll look at you threateningly, as in, I've already got 20 things on my panel, I can't do this. And so I just wondered if anyone has explored seeing if you could use that, create some prompts to identify these individuals. And then, of course, if you do find more individuals, the infrastructure that you've talked about, do you think for transplant, just to what Fred said, do you think we should be standardizing limited sobriety transplants just like we have some standardization for HCC as an example, where you have certain criteria, you have to actually imaging, et cetera. Do you think if we created that since it's the leading indication for transplant, maybe that's a way to help structure programs initially at transplant centers, but obviously then extend it?
Yeah. Let me take your first question, Paul, about your the coding of alcohol use disorder, and especially in relation to the primary care. In my opinion, the primary care will only address alcohol use in a patient where the patient has a problem list alcohol use disorder, is more likely to engage with the patient in talking to him at least for 30 seconds about, okay, stop drinking or something like that. But if you, I think there needs to be a national effort of incorporating an audit tool. It is there in VA system, but I don't think in most medical centers we have a tool built into the EMR that for primary care they have to address, like they have to address colonoscopy, PSA, blah, 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 but then smoking is there, but I don't think there is a tool which makes them not sign their note unless they address that audit tool. It's not in most medical centers to my knowledge. I think that needs to be built so that you can assess people with risky alcohol use and address that, and that may be something which is a barrier why these patients continue to have more progressive liver disease and cirrhosis when they present to doctors. Now, second question related to a transplant, I don't know the answer to that. I think in terms of alcohol use disorder and liver disease built in as an integrated care model for transplant, Lamia showed the Italian center back in 10, 15 years ago, the classical integrated care model. I think most of the centers, you and I, and most people here, hepatologists, including Bob Brown, who's sitting here in the panel, I don't think we apply an integrated care model. We do a good job in selecting patients who are not likely to or who are likely to relapse and excluding them from transplant. We do a fairly good job in that. But then the addiction people go their way, hepatologist goes their way. While the patient is waiting for transplant, there is no integration. And while the patient has a transplant and post-transplant follow-up, there is no integration. I think that's what, in terms of what you are asking about transplant, needs to happen so that there is integration right from the time of evaluation until the patient gets an organ and then follow-up after.
Well, and follow-up.
Yeah.
All right, thank you, Paul. Last question.
No, I'm Chatur from OSU in Columbus, Ohio. So thank you for a fantastic session. My question is more related to the role of the microbiome in alcohol, liver disease. You showed the data on Lactobacillus GG. Do any of you actually use it as a tool for your patients? You prescribe it? I get this question all the time from my patients. Can I use a probiotic or something like that?
Yeah, so I think Dr. Morgan showed excellent data on how microbiome can play a role. We know that, there is gut dysbiosis and permeability changes happening in the, and then translocation. We know all that, how the liver disease happens in these patients. And that gut dysbiosis and permeability changes are only happening in people, especially the permeability changes, only happening in people who are predisposed or who are likely to develop liver disease from drinking. But in terms of the therapy you are talking about, microbiome targeted therapies, in my mind, microbiome targeted therapies have a huge role and a promise for three reasons in my mind. Reason number one, that you are targeting the main pathology which starts the problem, or which starts the inflammation and which starts the pathophysiology. And number two, that I think changing the microbiome not only regulates or downsizes the inflammation, but in my mind, I'm not aware of any good data to show that changing the microbiome in a good way will improve the regeneration. So I don't think there is a lot of data to see the HGF levels in the liver go up or the IL-22 levels go up. I don't think there is good data, but I think, in my mind, I think the regeneration goes up if you improve the microbiome in a more healthy way. And the three, I think there is a gut-brain axis also where changing the microbiome not only improves the liver disease, but also the addiction. So I think it's a dual target. So I'm very hopeful of anything you do in the microbiome in a more positive way will help the liver disease and the addiction in these people.
Any comments, Tim?
No specific comments. I don't know how. Look, it's just. I think your data was good. The data you showed was good. I think that's good preliminary data, and somebody should follow up on it. But there's just not that much that's been done in the States on this.
Thank you.
All right. Okay. Well, I'd like to thank our panelists. Thank you so much. So this wraps up the second day. You know, we had a very important day today. We talked about problems that you guys all see at a very high rate. We talked about fatty liver, MASH in the morning, MET ALD, pediatric MASH, and then finished with alcohol. Tomorrow, we have the fellows breakfast. So any fellows that here are all invited at 7 a.m. To follow, there's another industry-sponsored talk on hepatitis B with Dr. Gish. And I think there's a second speaker. And then we follow with other problems that you guys do see in practice: autoimmune hepatitis, pregnancy-related liver disease, and other issues. It's a little bit of a potpourri tomorrow morning before we finish. So we hope to see everybody tomorrow. I want to remind you too, tonight at 7 is the CLDF reception with the top donors. It's in the promenade right in front of the exhibit hall to my right, your left, 7 to 8 tonight. So hopefully we'll see people there as well. Thank you guys. Have a good evening.